Dr. Parag sir to talk about uveal distractions, about lymphomas and masculates.
Yeah, the outside like to thank Dr. Prema for this opportunity. I'm very happy that we have one person in the audience and that no other than Mahesh Shanmugam sir. So thank you, sir.
I started when I saw this, sir.
So uveitic distractions, lymphoma and metastasis. So these are the things which can mimic a posterior uveitis. And the salient points of both are usually they are in the elderly age group, predominantly posterior segment involvement. And even if it is involved the anterior segment, it is usually a painless white uveitis, bilateral but not always. And uveitic workup is obviously negative. So intraocular lymphoma, it's a non-Hodgkin type B-cell lymphoma, and there's a primary and secondary. And primary is usually maybe associated with a CNS involvement. It's called as a primary vitreoretinal lymphoma, which is a high grade and more lethal. Then the secondary type, which is a metastasis from outside, is a low grade choroidal lymphoma, usually from the GI tract. So it's mandatory wherever you suspect a lymphoma, always do a neuroimaging and find out if there is any, because that changes the entire management, and from ocular it goes to the systemic treatment by an oncologist. The clinical features, as we know, are the multifocal subretinal epithelial infiltrates, which are pathognomic, and they can be associated with vitritis, and these pigments in 70% of the patients, and 20% can have anterior uveitis also, but it is usually a white uveitis. Again, when you see clinical features, history taking, always ask for CNS symptoms, and you will find that if there is a behavioral changes or something, then you must suspect that there could be CNS involvement, and always do a neuroimaging. And there's a PET CT showing that the lymphoma infiltrates in the brain. Other rarer type of presentations are choroidal mass, exudative retinal detachment, or optic disc swelling, and vasculitis with retinal hemorrhages can also present a lymphoma. Ocular investigations, we know the OCT now is one of the key imaging for diagnosis, and we can see the hyperreflective nodules at the level of the RP or sub RP. Along with the clinically, you can see these infiltrates. And fundus autofluorescence will show hyper autofluorescence surrounded by hypo, and the opposite by the fundus fluorescent angiography. So when it comes to diagnosis, always do a systemic evaluation first, rule out any systemic manifestations with doing an MRI, USG abdomen, if required a PET scan. If all is negative, then you go ahead with your vitreous biopsy. And biopsy you do in two things, undiluted and a diluted sample. Undiluted sample is usually around 1 to 2 ml. It's difficult to get it, but it can be done under air now. And diluted specimen from the vitrectomy cassette can be performed for the additional test. And it's mandatory that if the steroids have already started, then we should stop it before doing the biopsy, because it might come negative. And very important, the tissue has to be transported immediately. It's best to have a pathologist within in-house. If not, then within 60 minutes it has to reach to the lab. And if you expect some delay, then you have to fix it with ethanol, methanol, propanol, but that's not the ideal situation. And the test with the pathologist performs the cytological evaluation examination, which is the most diagnostic thing, but however the sensitivity is a little low in that, and the immunohistochemistry of CD22 and measurement of cytokine levels, and of course the molecular examinations with the MYD88 genetic mutations are the recent ones. And if the vitreous biopsy comes negative, then only you can go ahead and go with the more damaging retinal and the retinochoroidal biopsy. Ocular treatment, that whole globe EBRT is still it's fine. You can give a 40 gray in 15 fractions, but the side effects are cataract, radiation, retinopathy, dry eye. And now the intravitreal methotrexate, intravitreal chemotherapy with methotrexate and rituximab. The methotrexate was used initially and still being used. However, the regimen which was followed, which is quite intensive with weekly 4 injections and consolidation, weekly twice, then weekly once, and then monthly, almost 25 injections. And it ends up with a lot of keratopathy and other side effects. And so now there's a modified regimen which has only 7 injections. Like you give once a week for 1 month, 2 weekly for a month, and one for a month, and then wait and watch. And this is a recent case we saw in a clinic and we are finding this modified regimen, and she's finished 6 injections of this regimen, and it's doing pretty well, the patient. They got some keratopathy, but otherwise it's doing fine. Rituximab is a little costlier and a little less intensive because you have just to give 1 injection a month. But the thing is that it can also have uveitis, and you be careful that you treat that, or you pick it up early and treat that also simultaneously. So this was a 20-year-old female with a subretinal yellowish mass and exudative RD, and we sent for a evaluation. The oncologist did a PET scan. They found a lot of nodes involved everywhere. They did a biopsy, and treatment was started and progressed well, but it turned out to be tuberculosis and not a lymphoma. We can see that the age is quite less, not for lymphoma. This is a 23-year-old female. We saw a defective vision of 2 months, and you can see this hypopigmented large mass lesion on the posterior pole, and the B scan shows a calcification. So this is a case of a choroidal osteoma, mimicking like a lymphoma. Now coming to metastasis, bilateral multifocal, not always, but usually located preferentially at the posterior pole, and macula is involved in 42% of the eyes. So there are 3 forms: the flat amelanotic tumor with indistinct margins, as you can see here, the pigmented tumors with distinct margins, as seen here, and a large amelanotic dome-shaped tumor, as seen in this figure. Now, this case was already shown by Dr. Abhishek about the 47-year-old female who just came with a defective vision of 1 month duration, and you can see these nodules. But the point I want to highlight is that don't miss these subtle nodules everywhere else. You can see this, and this was taught by Dr. David Abramson even before the OCT era. That, and he correlated this to the peanut butter, the crunchy style. So we all like the peanut butter with the crunchy style, but the crunches are all hidden somewhere. So always look for that. In metastasis, you may see an obvious one mass, but then there'll be the entire choroid might be studded. And now we know with the shields, when they come with a lumpy, bumpy choroid, it's nothing but the same thing what was given by David Abramson even before the OCT era. This again was shown by my colleague. This is actually a large mass lesion, melanotic, mimicking like a melanoma, but actually the patient had a CA lungs, and we did a EBRT, and post EBRT you can see that it just melted out the tumor. Again, this patient came with a defective vision 1 month duration, this flat amelanotic lesion with like a CSR like thing referred to us, did a fluorescent angiography, and you can see the early hypofluorescence with the late staining, and this multifocal RP pinpoint leaks, and we referred to the oncologist, and it turned out to be a stage 4 CA lung. This patient came with a bilateral disc edema, diploma. There was a mastectomy and chemotherapy radiation were done for breast cancer in 2018, and we did a B scan, and B scan you can see this donut sign, and then it turned out to be a papilledema, actually, severe form, and it showed the metastasis of the leptomeninges. So this was a metastasis of the brain coming in the eye as a papilledema. So in conclusion, intraocular lymphomas and metastases are great mimickers of posterior uveitis. Careful history taking, clinical examination, multimodal imaging, and systemic evaluation can help in early diagnosis and proper management. Thank you.
Thank you, sir. It was